Our next speaker is Dr. Katie Bennett Richards. She's a consultant nephrologist in Royal London Hospital, and she's the training program director for rental training in Northern Thames, and she's also RCP SAC National Recruitment Member. Over to you, Katie, for the talk.
Thank you very much for inviting me to talk this afternoon. I'm going to talk to you about low clearance clinic set up in the low resource setting. I must admit to you that I have lots of experience of low clearance, but not so much in the low resource setting, but hopefully it will be useful for you. I asked ChatGPT to provide me with a logo for this talk, and it came out with this logo for me. I think that it implies that there's a certain amount of danger involved here, but providing we meet the metrics, we should make a clear run and not run into danger. What is low clearance? I mean, I've been doing low clearance for a while, and I've heard several different ways of describing the low clearance. It possibly isn't clear to a patient what low clearance is, but I'm not entirely sure that advanced kidney care is also entirely clear to the patient what is going on. We also use the terminology of pre-dialysis clinics also. So I think it might take some explaining to the patient what this is all about. Trying to define what is the gold standard here was a little bit difficult, as there's some different descriptions in different places. I turned to GIRFT, which is a UK-based system, getting it right first time. It's a system whereby services are investigated, interrogated, and visited so that we make sure that we're all performing as best as we can, learning from others. The other place I got some information from was the UK Kidney Association. So in my mind, the low clearance service is the gateway. Here's the gate, here's the field of renal replacement therapy, be whatever that might be. You can see that there are some other ways that you could enter this field, over the fence or through the ditch. So these are not the ideal methods, and these are associated with some risk, as you might imagine, falling into the water or getting caught on the barbed wire, and these will be our crash landers and not coming through our system. Is there any really defined way of knowing when a patient should come to this service? I found at least 4 different definitions, but I think it boils pretty much down to common sense and experience at the end. Some services will say an eGFR of less than 20 or 30, depending on your capacity. Within 18 months of requiring kidney replacement therapy is what GIRFT say. With a kidney failure ratio equation of more than 20% at 2 years is what UK Kidney Association say. And NICE is another set of guidelines within 12 months of requiring kidney replacement therapy. So what does GIRFT recommend? So it recommends for the low clearance service that you ensure patients are referred in a timely fashion, and as I've said before, ideally 18 months, and this may be equivalent to a kidney failure ratio of 20% at 2 years. It really places a lot of emphasis on the multidisciplinary team to provide timely access and appropriate education for all modalities, to improve access to transplantation, and to promote home therapies. And I think the figure that's quoted is at least 20% of your patients you should consider putting them on home therapies. So this will mainly be peritoneal dialysis, but it will also include home hemodialysis. We should continue to manage cardiovascular risk, and we should look at symptom and complication management that comes along, things like anemia and renal bone disease. What is the most important thing, I think, is the multidisciplinary team. To quote the definition, advanced kidney care refers to the multi-professional framework required to support high-quality patient care in those who are at a high risk of progressing to kidney failure and requiring kidney replacement therapy or supportive care. This is a real MDT in our offices in the Royal London Hospital. There are people online as well as in the room, and you'll notice one of my Sri Lankan colleagues here. we have specialist nurses, we have support nurses, and we have the dietitian online. However, if GERFT were to come along and look at this low clearance service, they would spot that we have some deficiencies. And these are probably in keeping with this, which was presented in 2018. These are the other members of the team that should be there, and you can see where the deficiencies are in social workers and psychologists, which is certainly what we struggle to meet that need. So what are the principles we've set up our clinic? What should we have in the forefront of our mind? We should think about the possibility of transplantation the minute the patient walks through the door. We should document our decision regardless of what it is, because we've come into trouble before when we've performed audit as to why patients are not on the waiting list, and we don't know why, and we think we might be doing a bad job. So good recording of yes or no on the transplant waiting list. We should ensure that all therapies have been discussed and thought through. We are in the fortunate position to some extent of being able to offer choice. We should have made a decision, and we should have some form of action towards that decision by the time we reach a kidney failure risk of 40% or more. We should consider other options for the patient. We don't necessarily need to go down the dialysis line straight away. And we should consider how best to support that patient with either supportive care or conservative care. And we should give education, it says, by this point in the patient's renal career. The advantage of using the equation is the inclusion of proteinuria, which may help with more predictive pattern. So the kidney failure risk equation you're probably all familiar with, and it's easily done. And I must say this is quite new to me, but I have used it as part of the toolbox to help us understand when a patient might reach that point when they need dialysis. It's not an easy thing to know, and a lot of it boils down to experience, because you have the rate of decline and you also have the amount of proteinuria. Also, our patients have intermittent episodes of ill health and acute kidney injury. So this is one of the tools in our box, but not the only one. About education, education is really important. I always tell the patients that if they're very much in the driving seat with everything that they know, they're in a good position to ask me questions. We have our own YouTube channel. I think local information is very useful given by our own patients. They're able to set the scene. They know what a lot of our patients are up against and where the resources might be best put and what might be most useful for our patients. There's also nationally available information, which I would urge you to have a look at if you haven't already, because it is, I think, applicable to most patients. The Kidney Care UK is an excellent resource for our patients. We run into trouble with language. I work in East London. We have people speak lots of different languages, and we're worried about whether we're actually getting the patient's point of view when we're talking through the relatives. This is an example of Kidney Care UK, which I discovered can translate any page into hundreds of different languages. This is one around diet, but it doesn't have to be diet. It could be around the basics of chronic kidney disease or dialysis. So I'd urge you to have a look if you're not already aware. So why bother with this low clearance clinic? Why not let them just come from all different sorts of clinics? Well, some studies have shown that it's really much more beneficial for the patient. They're more likely to arrive at dialysis in a timely fashion, they're more likely to have a kidney transplant, and their life expectancy is supposed to improve, and they have better access to dietitians. This is one of the things that patients say to me, is why are you telling me now? Why are you telling me now when my GFR is 15 about my diet? Why did you not tell me this before? And I think it's an omission in the previous part of our care, but it's something we should definitely focus on in the low clearance clinic. This is from the UK Kidney Registry, and it supports what we were just saying about improved outcomes. So the longer the patient is seen in the clinic, the more likely they are to have a transplant and less likely to have a non-tunneled line. If you arrive within 90 days, you're less likely to have the transplant here, and you're much more likely to have a non-tunneled line. What I don't quite understand is this line underneath, where you're most likely to have a transplant, but you're equally likely to get a non-tunneled line. I found little, actually, except in KDIGO when I was looking through about prevention. And having heard about the resource issues in low-resource and low-income countries, perhaps the money is best spent on focusing on prevention. This is from the Global Burden of Disease. This is published in The Lancet in 2018, I think, and it looks at the leading causes of mortality in 2016. Thankfully, the number of infection-related deaths are declining, and the three top are staying the same. But just look to see where the chronic kidney disease is moving from 16 to 5. This is probably because of its association with these conditions, but it's certainly somewhere where we should be focusing our attention. This, I must admit, took me a little while to understand, but this looks at the predicted premature deaths in years of lives lost globally. It looks at a best-case scenario in 2040 versus a worst-case scenario. And these are looking at drivers of health overall and its association with risk factors which are modifiable. You can see again that chronic kidney disease or impaired kidney function is all it says here, is coming in quite high, presumably because of its association with these other conditions. It's worth noting that in the worst-case scenario, tobacco overtakes a high BMI as a cause of years of life lost prematurely. So what about dialysis provision? We are thinking that we should be spending our time on prevention, and this graph here shows that the number of people who are on dialysis worldwide, or having renal replacement therapy, I should say, that includes transplantation. And you can see that more than half of this is in the high-income country. But does this mean that this have very few patients in the low-income countries? I don't think so. It's about the disparity in provision. Here we can see about the disparity in provision divided by income level of a country as defined by the World Bank. And you can see that there's an under-provision of 96% of the estimated number of people who need it versus the number who are receiving it. Rather interestingly, the high-income countries seem to be over-providing in this model published in The Lancet in 2015. This kind of describes a little bit more countrywide in terms of the income, and you can see quite nicely that the gap between the estimated number and the actual number gets wider and wider and wider as we progress. So it's not that low-income countries don't have patients that need dialysis, it's just patients that are not getting it. This is projected to worsen, as been alluded to in many of the other talks that we've already heard. I was quite interested to see this was published in the past, and that this is 2005. There's only another 5 years to go on this graph. So what about prevention then? We've talked about the low clearance setting. We've said that it's ideal that people don't end up in the low clearance to start with, but if they are, we should continue to talk about prevention. We shouldn't just be talking about the preparing for dialysis or kidney transplant, which is clearly important. So I think you're all aware of these issues. So primary prevention, no rocket science there. And interestingly, if you think about the global death graph, you're going to see that BP management and lifestyle is going to be a key indicator in improving patients' outcome. The secondary prevention is once we already have the patients. None of this will be surprising to you either. And also there's the raft of new medications that we should be asking ourselves whether the patient would benefit from and whether they have access. We should continue dietary adjustments. I think, again, dietary input is very important and patients really appreciate it. And of course, tertiary prevention in the management of uremic symptoms and comorbidities. So this quite nicely summarizes, I think, what we should be doing in the low clearance clinic, in addition to what the definition was in terms of preparation and access to transplantation. I think that we possibly don't spend enough time on lifestyle modification, and we rely a lot on others to get involved there, and it takes impetus on part of the patient to get onto that sort of program, like the exercise programs. And I think that perhaps we need a little bit more training in knowing what's out there for patients to improve their lifestyle modification. So we've talked about provision of low clearance and dialysis and transplantation. We've talked about prevention, but what about detection? Why not pick these people up right at the very beginning? This is a setting in a rural clinic in Nepal, thanks to one of my colleagues, Dr. Clara Padal, who's made great inroads in providing this kind of service in the rural parts of Nepal. Approaches to screening programs are improved awareness. I think you'll probably be aware of most of them. And integration with established non-communicable disease programs will often help where kidney programs are not in place, and widening participation. What might be the barriers? I think probably these are all already alluded to: the lack of awareness, the lack of central databases, and national programs being available. Also the workforce, and most importantly, an adequate health system infrastructure and data collection. This looks at the number of nephrologists, and I was interested to look at Sri Lanka, which is here in this pale green. Is this enough nephrologists? Well, the answer is no, this is not enough nephrologists in Sri Lanka. I was interested also to see that if anyone wants to go to New Zealand, they are short of nephrologists too. What about national strategies for non-communicable diseases? Yes, there is one in Sri Lanka and most parts of Asia. Is this anything to do with chronic kidney disease or non-dialysis as part of the national strategy? The answer is no. What about a register for chronic kidney disease? And the answer is yes, and this is a very good starting point. And what about other types of registries that low and middle income countries have? Well, it's the same as everywhere else. We're recording transplantation and dialysis very well, but not chronic kidney disease or acute kidney injury. I just wanted to spend a few seconds talking about a program that has been developed in the Royal London by one of my colleagues, and it's very much a pilot stage, but it does rely on the infrastructure and the registries and the ability to get data. We have a big problem with crash landers. So these are the people going over the barbed wire fence or through the ditch, not through the gate. So how can we reduce this? We've tried so many different methods. So what David has done is he has set up this automated metabolic screening service. Every night the hospital gives us information. We get a dump into our systems, giving us triggers which he has set. We're also fortunate to get additional information from primary care, also their diagnoses and their drugs here, so not just these biochemical parameters. He then created an optimization index. So this is automatically generated by the computer. At the end of the week, the consultants are asked to look at the patients that have come through this system, and have we got the crash landers? Have we got the GFRs of 5 out in their community that nobody's taken much notice of? The second thing is, are we optimizing these patients who do have chronic kidney disease? And with the index of 1, the answer is yes, and less than 1, the answer is no. And what makes up the index is the drugs, the doses, the BMI, the blood pressure. So he has designed a very nice automated system to look at the patients in our area and their risk of progression so that we can pick them up before they crash land. So factors to consider when setting up your clinic. We've been doing a clinic a long time, and sometimes, the one I was doing was started actually by Professor Yakub many, many years ago, and it has grown and it has grown. So it's to suit your own needs and to how your local population works. But what you will need is a source of accurate data, estimates of early and late chronic kidney disease, so you know where these patients are coming, you know where you want to set up this clinic. You're going to need your multidisciplinary team, but you can train people up to what your needs might be. You're going to need motivation and mentorship, which is part of the reason that we enjoy coming to these meetings, and you come to us and we learn from each other. incorporate research and audit. This will drive your service on to a very high standard if you have people looking at what you're doing, looking at the outcomes and seeing if you're achieving what you set your mind to achieve. And obviously links with the other programs. So this slide summarizes in the low-income countries or the low-resource countries what it is, the factors that you will need to consider in setting up your service, and I'm sure a lot of you already have your own service. The idea is that just like Sri Lankan Airways, we have a nice, shiny new plane, and it arrives nicely on the runway, in the center of the runway, without any injury and to great fanfare. So thank you very much for listening to my talk.